Okay, so I am talking about degenerative spine imaging, and I am sure that when everyone saw my title of my presentation, they were as excited about learning about degenerative spine imaging as you are about learning about the Krebs cycle. But honestly, degenerative spine imaging and topics like that they're just very common everyday topics that we run into. Actually, I get more questions, more engagement about that than I do on when I give talks about fancy, advanced imaging techniques. And I think it really speaks to the fact that, a lot of radiologists just really want to do a better job of taking care of the patients they see every day. And no matter what kind of practice you're in, academic, private practice, community practice, you will see degenerative spines, and it's important to be able to read them well. In fact, one of my fellows actually literally texted me this week being like, can you resend me this talk? I need to give it to everyone in my practice. So I hope that you guys find this helpful as well. Okay, I have nothing to disclose yet, but Rank and Ray, I'm open to sponsors. Okay, so the purpose of this talk is to kind of talk about how to be efficient at reading the degenerative spine, and then how to classify the degenerative spine abnormalities that we see in a way that's simple, reproducible, and evidence-based. So we'll talk about first about how to read a spine MRI for degenerative findings. And I don't care if you're a resident, 1 year out of practice, or 30 years out of practice. If you do this in a systematic way, you will be more efficient, you will miss things, and you'll really be able to get all of the findings. And I actually, from the time I was taught it as a resident, and I still teach it to residents today, I remember the A, B, C, and D of reading a spine. I literally go A, B, C, D. So let's do that. So A is for alignment. So, for trauma, we really think about alignment as, looking for instability. But in the degenerative spine, we're really looking for malalignment that causes advanced or early degenerative change. Abnormal motion in the spine causes the spinal elements to move against each other, kind of like grinding teeth abnormally. And this can wear the spine down and call early degenerative change. Additionally, our spine surgery colleagues like to talk about the perfect balance of the spine in its normal position. Evolution, you can't beat what evolution has decided, and the appropriate anatomic alignment of the spine that has been, shaped by, millions of years of evolution is the most energy efficient way to bear the weight of the human body. And anything that changes that alignment from the perfect alignment that evolution has found for us can cause you to exert more energy, cause more strain on both the bones and soft tissues, and cause pain. So it's really important to look at the alignment. And I'm not just talking in the sagittal plane. All the time, I tell my fellows, remember to look at the coronal localizer, because a lot of times it's a scoliotic curvature that may be causing pain. And in fact, edematous changes you may see of the end plate may be related to abnormal mechanics from a scoliosis rather than simply disc degeneration. So B is for bones. So on CT, we're looking for fractures, but on MRI, actually fractures are usually not well seen. You're usually looking for either marrow lesions or degenerative edema, either of the end plates or of the facets. And as we see more and more non-invasive or minimally invasive treatment of spine pain, these edematous changes are becoming more and more important as these basically physiologists and spine pain doctors are looking to treat these regions of marrow edema for sources of pain. So C is for, on CT, the canal, and for MR, the cord. So on CT, you want to look at the canal contents to see any sort of large disc or large mass that could be compromising the canal. On MR, you can see the canal pretty easily, but you want to go beyond that, and the C is for the cord. So you want to look for any sort of cord edema that could indicate degenerative myelopathy, or even cord deformity, because that can also cause degenerative myelopathy as well, even before you see cord signal abnormality. And finally, D is for discs or degenerative findings. So every time you look at a spine, the normal disc should look like a kidney on its side with like a little indentation for the renal hilum. And any change to this reniform shape means that there is a disc bulge. So the normal disc also has a very distinctive appearance on sagittal imaging. It kind of looks like the cross section of a jelly donut with the T2 bright disc, or probably bright aspects of the disc with a dark nucleus pulposus center. Now, when they degenerate, you lose that jelly filling and they start to look more like a pancake rather than the cross section of a jelly donut. So if you see flat pancakes, that means that that disc is degenerated. Now, several things can happen to a degenerative disc. First, you can get a bulge. Now, I think of a bulge kind of like gaining weight. When you gain weight, you slowly get fatter and kind of loosen your belt. Or for us doctors, right, we loosen the ties on our scrubs. For a disc, it's kind of the same thing. The annulus degenerates, kind of like a loosening belt, and the disc gets a pot belly, just like we do. So you lose that renal hilum as the belly kind of squishes or expands outward with the loosening belt of the annulus. Now let's talk about a disc protrusion. Now, a protrusion is different than a bulge. So if a bulge is kind of like loosening of your belt, you know, the annulus is lax, but still intact. A protrusion is more like a hernia. The annulus now tears and the disc herniates out. So this means that a protrusion is more focal and can happen more acutely. Next is extrusion. Now, an extrusion is when the herniated disc becomes like toothpaste. Because it's squishy, like toothpaste, the extrusion can move up and down in any direction from the parent disc. And it can have a smaller base than the dome because it can squish through tiny little holes, just like toothpaste. And finally is the free fragment. This is when an extrusion breaks off, kind of like when you break off the toothpaste onto your toothbrush. Now, you can see this on imaging because it's usually a different signal than the parent disc, and usually much more T2 bright because it's very edematous. I think of it as it's no longer bound to the parent disc to have the same signal. Like when you go off to college, you're no longer bound to act the way their parents told you to. You can now be your own person. Similarly, now a disc extrusion can have its own different signal. Some other degenerative findings that you should look for. In the cervical spine, there's another joint that is at the lateral margin of the disc called the uncovertebral joint. Now, normally this should look like cute little devil's horns on the coronal, but when it starts to look more irregular, more like a moose horn rather than a devil horn, that's when you have degenerative change. So you should look nice and smooth, like the smooth curve of a devil's horn, but if it looks irregular along its aspect, that's when you know it's degenerated. You should also look at the facets. Normally the facet should look like a little tiny baby hamburger. When the facet stops looking like a hamburger and looks more like a mushroom with that kind of overhang that you get with the mushroom, that's when you know that the facet is degenerated. So really, I think that spine reports are kind of like Mad Libs. Now, I don't know if the audience today is too young to remember Mad Libs, but you used to just fill in the blank. And that's essentially what you want to do for every spine report. You want to start with alignment, say what you see. Bones, mention any marrow edema. Canal and the cord, you want to look for any signs of cord flattening or cord signal abnormality, and then go level by level for the degenerative findings. And it truly is a fill in the blank. So at every level, you want to talk about what you see is happening with the disc. You see a bulge, a free fragment, an extrusion, and how bad is it? Same thing, you next move on to the facets, tell what's happening with this. Then you grade what these degenerative findings are doing to the canal and to the foramina. And you do that for every level. It is extremely formulaic, but it's extremely efficient as well. So let's talk about how we describe the degenerative changes that we see. So in 2012, they tried to survey spine experts to come to consensus as to what the most important criteria were for spinal canal and foraminal stenosis. And the consensus was that there was no consensus. So if the experts can't agree, what should you use to call canal or foraminal narrowing? So you don't just want to gestalt it, right? That's a recipe for inconsistency and disagreement. But you don't want to measure everything either. Now, not only is measuring it cumbersome, but measurements introduce interreader variability, right? You said it was 6 millimeters, I said it was 7. And absolute measurements don't always mean the same thing, depending on how you might be angling your imaging. So instead, we should think functionally. Now, the nerves in the lumbar spine need to fit in their space like you fit in clothing. So mild stenosis is kind of like comfy clothing, right? No squeezing. You got your sweats on and you're ready to, sit down and watch some Netflix. Moderate stenosis is like clothing that's not loose per se, but there's not extra room, but you can still fit in it. And severe stenosis is like those jeans from high school that you just have to accept that you cannot fit in. If you try to get in it, your body, truly gets compressed. So how do we tell if the nerves have enough room? If their clothing, shall we say, fits loosely, tight, or too tight? So what we do is we look at the space around them. Now, for the canal, it's CSF. If there's enough room, the extra space will be filled by CSF. For the foramina, it's fat. If there's extra room, it's filled by fat. So for mild canal stenosis, you can have attenuation of the CSF space, but there's still plenty of space around the nerve roots, just like there's plenty of room in your comfy sweatpants. For moderate canal stenosis, the canal starts closing in. So there's less CSF around the nerves and they appear more aggregated. It's kind of like, the clothing you wear out to the clubs, right? There isn't a lot of room between your skin and the clothing, right? It's showing off as much as you can with still fitting in, but you do still fit in the clothing. Now, for severe canal stenosis, these are your jeans from high school. You do not fit in them at all. So the canal doesn't just hug up to the nerve roots, it compresses them. Kind of like, if you have a big meal and you're trying to get into tight jeans, your belly is going to get squished and deformed in order to fit. Same thing with the nerve roots. They're squished. You cannot separate them from each other. So this classification isn't just easy to remember, it's actually evidence-based. This is the Lea classification that has excellent reducibility, not just among radiologists, but also among even non-radiologists. And it does correlate with increasing symptoms. So for the nerves in the foramina has fat around it on 4 sides that can be attenuated as the space gets tighter. Now, how many sides are attenuated determines how severe the stenosis is. So mild stenosis is where you have loss on the fat on 2 sides. So, it's still comfy clothing because, you do have fat on the other 2 sides, so you still have lots of space. Now, moderate stenosis, you lose the space on all 4 sides, but the nerve itself is not compressed or deformed. So kind of like that sleek outfit that, you bought for that special occasion, it shows off your curves, but it doesn't deform them. It's not comfy, like no one's wearing their dress clothes or club clothes out if they don't have to. And, like you wouldn't eat a lot if you're wearing like some tight clothing, but you can fit in it. It's not too small. There's no give, but you're not squished. So then for severe stenosis, again, trying to fit into those genes from high school, and it's not going well. So you're squishing everything you can in. So same with the foramen. The fat isn't just gone, but the nerve is compressed and deformed the same way your belly is when you're trying to fit into those old pants. So this is also named the Lea system. No conflict of interest with the Lea giving this talk completely differently. And it actually, is very concordant with the way we think about the canal stenosis for the other Lea classification system. It's also very reproducible, and it does correlate with findings at surgery. So remember, when you are looking at a lumbar canal, throw away your calipers, don't just gestalt it. Ask yourself, how well does the clothing fit? Is it comfy with room? Is it sleek along the skin? Or is it compressing? And that gives you your mild, moderate, and severe that is reproducible every time and easy to remember. Okay, let's take a last bit to do the cervical classification system. So in the lumbar spine, it's all about the degree of canal and foraminal narrowing. But in the cervical spine, we have another factor to think about, the cord. Cord integrity is key. No matter the degree of canal stenosis, if the cord isn't happy, the patient won't be happy either. It's like marriage. No matter how great your life is, if your spouse is unhappy, you're unhappy. No matter how wide the canal is, if the cord is unhappy, if there's deformity or signal within the cord, then you have a serious problem. So cord flattening, even without canal stenosis, can cause myelopathy. Now, no one's really quite sure as to why. Some say it's because mass effect on the static imaging doesn't really reflect how bad it is with dynamic imaging. Some say it's from, repetitive microtrauma. If you're, always against the cord, like kind of hitting it every time, that can cause myelopathy. And some say it's from microischemia because the compression of the ventral cord compresses ventral perforators. But the truth is no one really knows. But we do know that it can cause myelopathy even in the absence of canal stenosis. So you really need to think of it functionally. The cord sits in the CSF kind of like a fish sits in water. As long as there's plenty of, water for the fish to swim around, it's a happy fish. Similarly to the canal and the cervical spine, as long as there's fluid around the cord, it's a happy cord. So when we talk about mild, moderate, and severe, we're talking about the degree that we attenuate the fluid around the cord. So mild stenosis is when your fishbowl, kind of gets filled up by decorations on one side, but the fish still has room to swim around. Moderate means like you've added probably a little too many decorations, and now the fish doesn't have too much room to swim, and it's on both sides. And severe means there's just, you went all out with the decorations, and there's literally no more room for the fish to swim. So there's no room for the cord. So mild canal stenosis, so think of the fishbowl as the ventral and dorsal CSF. So mild canal stenosis is when either the ventral or the dorsal CSF is effaced, but the other side is still empty. The other side of the fishbowl is still there for the fish or the cord to swim around. So if you attenuate either ventral or dorsal, but not both, that's mild. Moderate canal stenosis, both sides of the fishbowl have been filled. So both the ventral and the dorsal CSF have been effaced. Now, the ability of that fish to swim has notably been limited. Similarly, there's not fluid on either the ventral or dorsal aspect of the cord. Finally, in severe canal stenosis, the bowl is completely filled and no CSF is seen. So there's no room for the fish in the fishbowl in this scenario. Similarly, there's no room for the cord and it's compressed. So not only is there no swimming, but it's been crushed. So this is severe canal stenosis. So this classification is really super easy and simple. It's also evidence-based, and it's called the Mule classification. Really reproducible. It doesn't correlate with pain, but it does correlate with outcome. So there is an evidence base to this really easy to remember system. But remember, in the canal, in the cervical region, canal stenosis isn't enough. Cord flattening can cause myelopathy regardless of the degree of canal stenosis. It's like being punched in the face, right? No matter how far away the punch comes from, it still hurts. Similarly, cord flattening is like being punched. No matter how much room you have on the other side, it still hurts and you can still be myelopathic. So cord flattening has 3 degrees. Either it's not there, it's there, or it's so bad that it causes cord damage. So you can kind of think of it like a fight. Cord deformity without signal is like someone, pushing you to start a fight. You can still walk away. But cord deformity with signal is like a punch to the face. It's totally on. The damage has been done. So here are some examples. Here at the top, you can see there's cord deformity without abnormal cord signal. So this is grade 2. It's kind of like someone pushing you, but no real harm has been done. It's just your pride. Now, lower down, you can see that this is grade 3. There is deformity and cord signal. This is when they've punched you and now, you can't back out of that fight. I don't care what Michael Jackson says, you're not going to beat it at that point. So, the fight has started, the cord already has a black eye, you're not backing down from the fight. So, cord deformity without signal and cord deformity with signal are very important for you to see. So even if they only have moderate canal stenosis, if they have cord signal abnormality, it is still a very significant finding, and it increases the urgency with which the patient needs to be treated. So remember, this is independent of the degree of canal stenosis. So you can have cord deformity even if there's lesser degree of canal stenosis. This is called the King classification system, and it was created to kind of bring the idea of cord flattening into the assessment of cervical spine stenosis because, flattening can contribute to myelopathy regardless of stenosis. So you don't just want to look at the degree of canal stenosis in the cervical spine. So you might ask, why don't we just use the measurements for the cord flattening and forget about the canal stenosis if that's so important? The problem with that is that if there's no cord signal, then many degrees of canal stenosis are equal. So here you can see there's mild canal stenosis with grade 2 flattening. And on the other side, you can see there's severe canal stenosis with grade 2 flattening. So if we don't grade the canal stenosis and only talk about the degree of cord flattening, then we miss things that may also be important, such as the overall degree of canal stenosis, because that places you at greater risk of progressing to grade 3. So this is why we use both. So for every level, you want to rate the degree of canal stenosis and the degree of cord flattening. And there's really not one classification system that, encompasses these both. So I use both classifications at every single level I do. So remember, in the cervical cord, canal and cord both matter for degenerative findings. So we've talked about how to approach the canal with your degenerative spine with our A, B, C, and D. We've talked about simple, easy, reproducible ways to grade cervical and lumbar degenerative findings without having to break out your calipers. So hopefully this hasn't been too much of a pain in the back to listen to. Thank you very much.